He was dying in my hands. I felt his ribs crack under the force of my compressions, a sickening sound I'll never forget. The chaos of the code blue was a deafening roar, but in that moment, everything narrowed to the space between my palms and his still chest. And then it happened. His eyes, glazed and distant, fluttered open for a mere second. He looked directly at me, and he blinked twice. It wasn't a reflex, it was intentional. A final, desperate message from a man straddling the line between life and death. That single, silent signal shattered everything I thought I knew about emergency medicine. It set me on a path that would challenge the very foundations of our protocol. My name is Grace, and that night, a dying man's blink taught me a terrifying truth about the final moments of life. Before that night, my world was the emergency department of San Lucas Hospital, a place of controlled chaos where every second was measured in heartbeats and every decision carried the weight of a life. I was Grace, a senior nurse who prided herself on her composure, on the ability to build a wall between the overwhelming tide of human suffering and the precise, methodical execution of my duties. I knew the rhythms of that place by heart, the steady beep of a stable monitor, the frantic alarm of a crashing patient, the hushed, rapid-fire language of a trauma team in motion. My confidence was built on a foundation of protocols, thick binders of procedures that told us exactly what to do, when to do it, and for how long. They were my Bible, and I was a faithful believer. We all were. We had to be. To question them was to invite doubt, and doubt in an emergency room is a luxury no one can afford. It was a fortress of certainty, and I felt safe within its walls, believing we were fighting the good fight with the best tools science could provide. The patient was a John Doe when he came to us, a man in his late 60s found unresponsive in a small apartment downtown. There was no family rushing in behind the gurney, no one clutching a photo or crying out a name. He was just a man, alone, his life story reduced to the vital signs scrolling across the screen and the few personal effects in a clear plastic bag. He had a kind face, even in the profound stillness of his sedation, with lines around his eyes that spoke of a lifetime of smiles. We stabilized him, treating the symptoms of a massive heart attack that had stolen his consciousness, and moved him to the ICU for monitoring. He was just another patient in a long line of patients, another life to be fought for according to the pages of our protocol. I remember checking his lines, adjusting his drip, my movements efficient and automatic. I noted the strength of his pulse, the shallow rise and fall of his chest, and I thought, like I had 1,000 times before, that we had caught him in time. The machinery was doing its job and we were doing ours. The fortress felt secure. My shift was supposed to end at 11 p.m., but the ICU was short-staffed, a chronic condition in our hospital, so I stayed on for a few extra hours. I didn't mind. The night shift had a different tempo, a quieter, more intimate kind of intensity. The overhead lights were dimmed in the corridors, and the cacophony of the day gave way to the solitary sounds of the night, the soft hiss of oxygen, the rhythmic compression of a ventilator, the occasional murmur from a restless patient. It was during one of my final rounds that I paused by his bed. The room was bathed in the soft blue-green glow of the monitors, casting long, dancing shadows on the walls. Everything was stable. His heart rhythm was irregular but holding, his blood pressure was within acceptable limits. I was about to turn away to write my final notes and hand over to the next shift when I saw his hand twitch. It was a subtle, almost imperceptible movement, but in the absolute stillness of that room, it was as startling as a gunshot. I leaned in closer, my nurse's instinct overriding my fatigue. "Senor?" I whispered, my voice barely audible. "Can you hear me?" There was no response, no change in the steady waveforms on the screen. I chalked it up to a myoclonic jerk, a common, meaningless muscle spasm in sedated or critically ill patients. It was in the protocol, a footnote under expected neurological observations. I was just about to dismiss it entirely when I saw his eyelids flutter. Not the rapid eye movement of sleep, but a slow, deliberate struggle. It was as if he was fighting through layers of thick, heavy cloth, trying to force his way back to the surface of consciousness. My own breath caught in my throat. This was different. This wasn't a reflex. I placed my hand on his arm, a gesture meant to be comforting, and said his temporary name. "It's okay, Juan. You're in the hospital. You're safe." And for a single, heart-stopping second, his eyes opened. They were clouded with drugs and exhaustion, but they weren't vacant. They focused. They found my face in the dim light, and in them I saw a flicker of something profound, not confusion, but a deep, resonant awareness. Then, as quickly as it came, it was gone, and his eyes closed. His body sinking back into the depths of its medical slumber. I stood there for a full minute, my hand still on his arm, my heart pounding a strange, irregular rhythm against my ribs. The monitor continued its steady, reassuring beep, but for the first time in my career, its song felt incomplete, like it was missing the most important verse. I had followed the protocol to the letter, but in that silent, glowing room, I had the unnerving feeling that the protocol hadn't told me the whole story. The rest of my shift passed in a blur of automated motions, my body performing its duties, while my mind remained anchored in that dimly lit room, tethered to the ghost of awareness I had seen in Juan's eyes. I administered medications, documented vitals, and gave report to the day shift nurse, all while replaying that fleeting moment on a loop inside my head. Had I imagined it? Was it merely a trick of the low light and my own exhaustion? The rational, protocol-trained part of my brain argued vehemently for a simple physiological explanation, but the deeper, instinctual part, the part that had felt the intensity of his gaze, knew it was real. That knowledge settled in my stomach like a cold, heavy stone. Driving home as the sun painted the horizon in hues of orange and pink, the world outside my car window seemed strangely muted. The normalcy of people starting their days feeling like a scene from a play I was no longer part of. I couldn't shake the feeling that I had witnessed a crack in reality, a glimpse into a space medicine had no maps for. Sleep was impossible. I lay in my bed, the silence of my apartment amplifying the memory of the monitor's beep and the image of his struggling eyelids. I kept thinking about the protocol, our sacred text. It told us how to assess brainstem function, how to declare brain death, how to manage sedation. It had entire chapters on the body's machinery. But it was silent on the occupant. It never asked the question, what if the lights are still on, even when the house appears dark and silent from the street? What if the person is still in there, trapped behind a wall of paralyzed flesh and chemical-induced silence, aware of the tubes, the sounds, the frantic discussions about their own viability happening just inches away? A profound sense of unease, a responsibility I hadn't asked for, began to wrap itself around me. This wasn't just about one patient. It was about the fundamental assumptions we made every single day for countless vulnerable people. I returned to the hospital that evening for my next shift with a new, singular purpose. I went straight to the ICU, my heart thudding against my ribs. But Juan's bed was empty, stripped clean, the mattress bare. A cold dread washed over me. The charge nurse saw my expression and gently informed me that he had been transferred to a specialized cardiac unit in another wing early that morning. His condition had stabilized enough for the move. The relief was immediate and overwhelming, but it was quickly followed by a renewed determination. He was alive. He was conscious enough to be moved. This wasn't a story that ended at the brink of death. It was a story that was still being written. I knew I had to see him again, to look into his eyes and see if that awareness was still there, to try and understand what he had experienced. My duties in the ER kept me anchored, but during my break, I made my way to the cardiac unit. I found him in a semi-private room, awake. He was propped up on pillows, looking frail and tired, but undeniably present. An oxygen cannula rested in his nose and an IV line snaked into his arm. When I entered the room, he turned his head slowly towards me, and he smiled. It was a weak, tired smile, but it was unmistakable. "You," he said, his voice a dry, raspy whisper. "The nurse from the dark room." I felt a shiver run down my spine. He remembered. I pulled up a chair beside his bed, my professional composure melting away into something far more human. "My name is Grace," I said softly. "You gave us quite a scare." He nodded slowly, his eyes, now clear and focused, holding mine. "I remember the dark room," he whispered, "and the lights, so many little lights. Blue and green, dancing on the ceiling." He described the shadows I had seen. He described the hiss of the ventilator. He was piecing together sensory details from a time when, according to every chart and monitor, he was supposed to be profoundly unconscious. I took a slow, steadying breath. "João," I began, choosing my words with immense care. "Do you remember anything else from when you were in the ICU?" He was silent for a long moment, his gaze turning inward, navigating the foggy landscape of his recent trauma. "I remember feeling like I was underwater," he said, his voice gaining a sliver of strength. "Everything was heavy and far away. I could hear voices, but they were echoes. I remember trying to move, to shout, but I had no voice. My body wouldn't listen." He paused, and his eyes found mine again, a flicker of the same profound intensity I had seen before. "And I remember you. I remember your hand on my arm. It felt solid, an anchor. I was trying so hard to tell you I was there. I tried to open my eyes. I tried to blink." My blood ran cold. The confirmation was both terrifying and exhilarating. He had been conscious. He had been aware of his own paralysis, aware of his surroundings, and aware of his desperate internal struggle to communicate. The protocol had failed to see him. It had registered his body's functions, but had completely missed the person screaming silently inside. I sat with him for a long time, not as a nurse to a patient, but as one human being to another, listening to his fragmented, haunting account of existing in that liminal space. He wasn't a John Doe anymore. He was João Silva, a retired bookkeeper who loved jazz and had a cat named Socrates. He was a person, and for a critical period of his care, our system had rendered him invisible. Walking out of that room, I knew my life as a nurse had irrevocably changed. The fortress of protocol hadn't just been challenged, a fundamental crack had been blown right through its main wall, and through it, I could see a vast, uncharted territory of human consciousness that we, in our haste to save lives, had completely ignored. I know many of you watching have your own stories, your own moments that made you question everything you thought you knew. Maybe it was in a hospital room, or perhaps in a completely different situation. Where are you from? And has life ever presented you with a mystery that changed your perspective in a single, unforgettable moment? I'd be so grateful if you'd share the name of your city in the comments below. It's comforting to know we're all navigating these profound questions together, no matter where we are. Armed with João's testimony, a quiet revolution began to brew inside me. It was no longer a vague unease. It was a concrete, undeniable truth that I now carried. A secret that weighed heavily on my conscience with every shift I worked. I started to look at my other patients differently, especially those lying in the hushed, technological solitude of the ICU. The man with a traumatic brain injury from a car accident, the woman recovering from complex surgery, the elderly patient with sepsis. Were they too trapped in that silent underwater world Zhuang had described? Every twitch of a finger, every flutter of an eyelid, which I had previously cataloged as involuntary reflexes, now felt like potential distress signals. I began spending a few extra minutes at each bedside, talking to them as if they could hear me, explaining every procedure, offering a running commentary on the day, my voice a deliberate anchor in the sea of their possible isolation. My colleagues noticed the change. Some appreciated the extra compassion, but others exchanged subtle, knowing glances. I was breaking an unspoken rule. I was investing too much. I was blurring the line between professional detachment and emotional involvement, and in the high-stakes, high-burnout environment of the ER, that was seen as a dangerous path. The turning point, the event that changed everything from a personal conviction into an unavoidable professional conflict, arrived with a new patient. His name was Samuel, a 40-year-old teacher who had suffered a catastrophic stroke. He was completely paralyzed, unable to speak or move, existing in a state known as locked-in syndrome. The neurologists had confirmed it with their batteries of tests. His cognitive functions were largely intact, but his body was a prison. He communicated through a sophisticated eye-tracking computer, his only window to the world. One afternoon, his monitor began to shriek, a sudden, dangerous cardiac arrhythmia. A code blue was called. The room instantly flooded with the controlled chaos of the resuscitation team. I was at the head of the bed, managing his airway, my view of his face clear. As the doctor began calling out for defibrillation pads and the crash cart was wheeled in, I saw Samuel's eyes. They were wide, filled with a pure, unadulterated terror. He was looking directly at me, and then his gaze darted frantically towards the cardiac monitor, displaying his own heart's fatal dance. He knew. He understood exactly what was happening to him. He was fully conscious, trapped inside a dying body. Watching us prepare to fight for a life he was experiencing the imminent end of. The team worked with practiced, brutal efficiency. The protocol was clear. As the doctor charged the defibrillator, he called out the standard warning, "Clear." Everyone stepped back from the bed. But in that split second before the jolt of electricity was delivered, Samuel's eyes locked onto mine with an intensity that felt like a physical blow. It was a silent scream, a plea, a confirmation of every fear Zhuang had planted in me. His body arched with the shock, then fell still. The rhythm on the monitor normalized. The crisis was averted. The team sighed with collective relief. A successful save. But I was frozen, my hands still holding the airway equipment, my heart pounding for an entirely different reason. I had just witnessed a man experience his own near death in a state of complete, horrifying awareness. The protocol had saved his heart, but it had completely ignored the terrified mind housed within it. As the team dispersed, chatting about the successful intervention, I stayed. I leaned close to Samuel, my voice low and steady. "It's over, Samuel. You're okay. Your heart is stable now." A single tear escaped the corner of his eye and traced a path down his temple. He then slowly, deliberately moved his eyes to look at his communication screen. With immense effort, he typed out 2 words that shattered the last of my professional complacency. I was awake. That moment became my Rubicon. I could no longer remain silent. I scheduled a meeting with the head of the ICU, Dr. Almeida, a brilliant and respected man whose entire career was built on the bedrock of evidence-based medicine. I walked into his office, a folder containing my detailed notes on both Juan and Samuel clutched in my sweaty hands. I laid it all out for him, the intentional blink, João's detalhado recolheção de seu unconscious state e agora Samuel's terrorífico real-time confirmação. Eu expoquei passionadamente about the need to re-evaluate our sedation and communication protocols para não responsivos pacientes, to formally consider the possibility of covert consciousness. Dr. Almeida listou pacientemente, stippling his fingers. Quando eu finicei, ele saiu, sound de weary pragmatismo. Grace, you are an excellent nurse. Your dedication is commendable. But what you're describing are anecdotes, powerful to be sure, but anecdotes nonetheless. Our protocols are built on decades of rigorous scientific research, on data, on reproducible results. We cannot and should not overhaul a system that saves countless lives based on a few isolated, emotionally charged incidents. We treat the body, Grace. We follow the physiological evidence. What you're talking about ventures into the unquantifiable, the philosophical. It's a distraction from the hard, fast work of emergency medicine. He gently pushed the folder back towards me. Don't lose your objectivity. It's what makes you so good at your job. I left his office feeling utterly deflated. The fortress walls hadn't just held. They had politely, firmly reminded me of my place within them. My truth was not their truth. My evidence was not their evidence. I was a storyteller in a world that only trusted spreadsheets. The crack I had seen now felt like a chasm separating me from the very institution I had dedicated my life to. Returning to the emergency department after that meeting felt like stepping back into a foreign country where I no longer spoke the language. Every beep of a monitor, every page over the intercom, every efficient movement of my colleagues now seemed to echo Dr. Almeida's dismissal. I was an island in a sea of protocol, and the chasm between my lived experience and the institution's accepted reality widened with each passing hour. The first major challenge came subtly, in the way my colleagues began to interact with me. The easy camaraderie we'd shared for years grew strained. Where once they'd valued my insights during trauma alerts, I now noticed a slight hesitation before my suggestions were implemented. My insistence on verbally explaining procedures to sedated patients, which I had adopted after Joao's experience, was met with polite smiles that didn't reach their eyes. I overheard two senior residents one evening, their voices low outside the supply room. "She's spending 15 minutes talking to a comatose head trauma," one said. "We're backed up with 3 chest pains in triage, and she's having a philosophical debate with a vegetable." The other sighed. "It's a shame. Grace was one of the best. But this consciousness crusade of hers is becoming a liability." The words didn't just hurt, they isolated me. My credibility, my most valuable currency in this high-stakes environment, was being devalued with every whispered conversation and sidelong glance. The professional isolation soon bled into tangible consequences for my patients. A few days later, we had a middle-aged woman, Maria, admitted after a cardiac arrest with a return of spontaneous circulation. She was heavily sedated and on a ventilator. Following my new self-imposed protocol, I was at her bedside, speaking calmly as I suctioned her endotracheal tube. "Maria, you're doing great. I'm just going to clear your breathing tube now. It might feel a little strange, but it will help you breathe easier." The attending physician, Dr. Costa, a no-nonsense man who had always respected my work, entered the room. He watched me for a moment, his expression unreadable. After I finished, he pulled me aside, his voice firm but not unkind. "Grace, we need to talk. Your patient load is backing up. I have 2 nurses handling 4 critical patients each, and you're taking twice as long with one. I understand you have new theories about patient care, but in my ER, the primary theory is that we keep people alive. We do that with speed and efficiency, not with monologues delivered to an unresponsive brain. He assigned Maria to another nurse, explicitly stating that standard, time-efficient care was to be administered. I stood there, my cheeks burning, feeling the weight of his decision. It was the first time my patient advocacy had directly resulted in a patient being taken away from me. It was a clear message. My methods were a luxury this department could not afford, a deviation from the norm that compromised the machine-like efficiency required for survival. The most painful challenge, however, came from a place I hadn't expected, my own self-doubt. Lying awake at night, the sterile, rational voice of Dr. Almeida would war with the haunted, pleading eyes of Samuel in my memory. What if they were right? What if I was projecting meaning onto random neurological misfires? What if my emotional involvement with Juan had clouded my clinical judgment, turning me into the very thing I'd always guarded against, a nurse who let her heart overrule the cold, hard facts? This internal conflict began to erode my confidence at the bedside. During a complex intubation, my hands, usually so steady, trembled slightly. I second-guessed a medication dosage, needing to double-check the protocol twice, a delay that earned a sharp look from the anesthesiologist. The unshakable grace the nurse others relied on in a crisis was faltering. I was becoming hesitant, less decisive, trapped between the two irreconcilable truths warring inside me. The fortress of protocol I had once found so comforting was now a prison. And the key I held, the knowledge of covert consciousness, seemed to only lock the doors tighter. The breaking point arrived during a particularly chaotic night shift. A multi-vehicle accident on the freeway flooded our trauma bays with critical patients. It was all hands on deck, a symphony of controlled chaos where every second and every motion counted. I was assigned to a young man, Lucas, with a severe head injury. He was intubated, sedated, and his prognosis was grim. We were stabilizing him for an emergency CT scan. The room was a whirlwind of activity. Orders being shouted, IV lines being placed, the respiratory therapist bagging him. In the midst of it all, as I was securing his cervical collar, I saw it, a single tear welling in the corner of his closed eye and tracing a slow path down his grimy temple. My breath hitched. It was just like Samuel. In that moment, the two worlds inside me collided. The protocol-driven nurse screamed that it was simple lacrimation, an autonomic reflex in brain-injured patients, utterly meaningless. But the nurse who had looked into Joao's aware eyes, who had read Samuel's "I was awake," felt a cold certainty settle in her soul. He was in there. He was terrified. He was feeling the pain, the chaos, the profound violation of his body's autonomy. I froze. The chaos of the room seemed to fade into a dull roar. I looked at the tear, then at the team working around me with brisk, life-saving efficiency. Should I say something? Should I stop this machine, if only for a moment, to offer a word of comfort to the person trapped inside? But the memory of Dr. Costa's reprimand, the whispers of my colleagues, the weight of my own crumbling confidence paralyzed me. To speak up would be to invite ridicule, to be seen as causing a dangerous delay over a meaningless tear. The seconds stretched, each one an eternity of moral agony. I did nothing. I swallowed the words, turned away from that tear, and continued my tasks like the efficient, protocol-following robot I was supposed to be. We rushed him to CT, and the moment passed, but the shame that washed over me in its wake was more debilitating than any fear or doubt I had felt before. I had chosen the fortress over the person trapped at its gates. I had prioritized my standing with the institution, over the silent plea of a human being in my care. In trying to navigate the complications of my new reality, I had committed the greatest betrayal against my patient and against the truth I now knew in the deepest part of my being. The challenges weren't just external anymore. They had carved a hollow space inside me, and I was no longer sure who I was or what kind of nurse I had become. The shame from Lucas's tear followed me like a ghost for days, a constant, corrosive reminder of my failure. I moved through my shifts like an automaton, my hands performing their duties, while my spirit felt detached, floating somewhere near the ceiling, observing a nurse who had forgotten her own conviction. The professional coldness I received from my colleagues had solidified into a permanent chill. I was given the least complex patients, my assignments carefully curated to minimize my idiosyncratic influence. The message was clear. I was on probation, not officially, but in the court of shared opinion that governed the daily life of the ER. Then, the event that would become the climax of my entire crisis arrived, not with a shout, but with the soft, rhythmic beep of a fetal heart monitor. A young woman, Elisa, was admitted in her third trimester with severe preeclampsia. Her condition deteriorated rapidly, escalating into full-blown eclampsia, and she suffered a series of catastrophic seizures that led to respiratory arrest and ultimately a loss of all measurable brainstem reflexes. She was declared brain dead. The protocol was unequivocal. She was now, in the eyes of medicine, a deceased person. Yet the tiny 28-week-old life inside her womb still had a strong, steady heartbeat. A devastating, miraculous, and ethically complex situation had been placed in our laps. The decision was made to keep Elisa's body on life support, a biological vessel to give her baby a fighting chance at viability. I was assigned to her care. The room felt like a sacred and horrifying space, a limbo where death and life were forced into an unnatural partnership. I tended to the machinery that breathed for Elisa's body, that regulated her blood pressure, that nourished her tissues, all for the sake of the child who kicked and turned within her. The official protocol was sterile and precise, maintained somatic stability for the fetus. It spoke of uterine tone, hormone levels, and nutritional support. It did not have a single line about the mother. She was a collection of organ systems, a failed biological unit being used for a higher purpose. But as I stood there, listening to the powerful, determined thump, thump, thump of the baby's heart and the mechanical hiss of the ventilator, I couldn't see a collection of organs. I saw Elisa. I saw the wedding band on her finger, the faint stretch marks on her belly, the family photos her devastated husband had taped to the bedrail. And the memory of Joao's blink and Samuel's terrified eyes screamed inside my head. What if the finality of brain death was not the finality of the self? What if some echo of Elisa remained, tethered to this body, aware of this profound post-mortem violation? The protocol said it was impossible. My experience whispered that we simply didn't know. One quiet night, as I was alone in the room charting her vitals, I saw it, a single, perfect tear, just like Lucas's, welling in the corner of Elisa's eye and tracing a path down her temple. My entire body went cold. It was an impossible tear. A brain-dead body does not produce emotional lacrimation. The textbooks, the protocols, Dr. Almeida, they would all say it was an autonomic reflex, a random firing of a dying nervous system, utterly meaningless. But I had seen this before. I had been wrong before. This time, I couldn't look away. This time, the cost of silence was too high. I leaned in close, my heart hammering against my ribs, my voice a trembling whisper. Elisa, Can you hear me? If you can understand me, if you are in there, please give me a sign, just one." I watched her face, her utterly still face, for what felt like an eternity. Nothing. Just the relentless mechanical rhythm of the ventilator. Deflation, heavy and cold, began to settle in my chest. I had finally lost it. I was seeing ghosts, projecting my own desperate narrative onto the empty shell of a woman. I was about to straighten up, to surrender fully to the protocol's cold certainty, when I saw the faintest twitch at the corner of her mouth. It was so subtle I almost dismissed it as a trick of the shifting shadows from the monitors. But then it happened again. A tiny, almost imperceptible spasm, a flicker of movement that was entirely isolated from the rest of her perfectly still face. It wasn't a random twitch. It was focused. It was in the same muscle group one uses to form a faint, sad smile. A sob caught in my throat. I didn't know what to do. This was the frontier. This was the uncharted territory I had glimpsed through the crack in the protocol, and now I was standing in it, utterly alone. I had no procedure for this. No binder told me how to communicate with a consciousness that medicine had already declared extinct. I reached out and took her hand, a gesture that was now strictly forbidden by the new boundaries of my assigned duties. "I see you, Elisa," I whispered, my voice breaking. "I don't know how, but I see you. We're trying to save your baby. Your little girl is so strong. She's fighting." And then the most profound and terrifying confirmation of my entire journey occurred. The heart rate monitor for the baby, which had been steadily beeping in the 140s, suddenly spiked. The number jumped to 160, then 165, holding there for several seconds, a clear physiological reaction to external stimulus, before slowly settling back to its baseline. The baby had heard me. The baby had reacted to the sound of my voice, to the emotion in it. I was delivering to her mother, and in that impossible, beautiful, and horrifying moment, I knew with every fiber of my being that Elisa had heard me too. I was no longer standing at a crack in the fortress wall. I was witnessing the wall itself crumble into dust, revealing a truth so profound it threatened to rewrite everything we understood about life, death, and the unbreakable bond between a mother and her child. This journey from a single, intentional blink to this moment in a room where life and death intertwine has been the most challenging and transformative of my life. It has cost me my professional certainty, my easy camaraderie with colleagues, and many nights of peaceful sleep. But it has given me something far more valuable, the unshakable conviction that we must always look deeper, that we must listen to the silences between the beeps of the monitors. The human spirit is far more resilient and mysterious than any protocol can ever account for. If this story has resonated with you, if it has touched a memory or a question in your own heart, I would be so honored if you would join our community here by subscribing. Every single one of us carries stories that challenge the ordinary, moments of profound connection or mystery that shape who we are. In the comments below, would you feel comfortable sharing a small piece of your own story? You don't have to use names or specific details, but perhaps just the feeling it left you with or the question it planted in your soul. Your experiences are just as valid and important, and in sharing them, we remind each other that we are not alone in navigating the beautiful, mysterious, and often overwhelming journey of being human. The days following the impossible moment with Elisa were a strange, suspended reality. I continued my shifts, but the weight of what I had witnessed was a constant, humming presence beneath the surface of my daily tasks. I didn't speak of it to anyone. Who could I tell? Dr. Almeida would have had me committed for a psychiatric evaluation. My colleagues would have seen it as the final, definitive proof of my descent into irrationality. So I carried the secret alone, a sacred and terrifying burden. My focus shifted from trying to convince the institution to quietly, steadfastly acting upon my new understanding. Alyssa's care became my sole, silent mission. I spoke to her constantly, updating her on her daughter's progress, reading aloud from the books her husband left, describing the weather outside her window. I treated her not as a deceased body, but as a mother in a state of profound, unimaginable limbo. I watched for any sign, any flicker, but none came again. The single tear and the faint muscle spasm remained a solitary, monumental event. A secret shared between the two of us and the child who continued to thrive within her. The medical team, of course, saw none of this. They saw a nurse providing exceptional, if slightly eccentric, care to a unique clinical situation. They noted the stability of the maternal body and the excellent growth parameters of the fetus. In their eyes, the protocol was working perfectly. After 3 weeks on life support, the fetal surgeons determined the baby had reached a viable gestational age. The decision was made to perform a post-mortem cesarean section. The day of the surgery, the atmosphere in the operating room was solemn and deeply respectful, but also starkly clinical. Eliza was wheeled in, a surgical drape placed to shield the view of her face from the field. I was permitted to assist, my role to monitor the maternal vital signs, a cruel irony that was not lost on me. As the surgeon made the incision, I found myself holding my breath, my eyes fixed not on the surgical field, but on Eliza's face, visible to me from my angle. I whispered to her, my voice a thread of sound beneath the murmur of the surgeons and the beep of the monitors. "It's time, Eliza. Your daughter is coming. She's going to be so loved." And then a tiny, mewling cry filled the room. They lifted a small, perfect baby girl from the incision, her skin pink and her fists flailing. The neonatal team whisked her away to a warming table, and the sound of her strong, indignant cries was the most beautiful and heartbreaking sound I had ever heard. It was then that I saw it. As the baby's first cry echoed in the sterile air, the monitor tracking Elisa's somatic functions, which had been a flat, steady line for weeks, registered a single, sudden, and massive spike in blood pressure. It was a physiological impossibility for a brain-dead patient. The anesthesiologist frowned, tapping the screen. "Artifact," he muttered, "must be a line issue." But I knew it wasn't. It was a final, powerful autonomic response, a mother's answer to the sound of her child's voice. A few moments later, as the surgeons began to close, Elisa's heart, which had been beating steadily under the command of the ventilator and medications, went into a fatal, irreversible rhythm. They called a code, a perfunctory, hopeless effort. As they worked, I stepped back from the bed, my task complete. There was no fight left in this body. Its purpose had been fulfilled. I looked at Elisa's face one last time, and in the profound stillness that settled over her after the official time of death was called, I felt not a victory, but a profound, quiet peace. The battle was over. She was free. In the aftermath, something subtle began to shift within me, and surprisingly, within the department. The successful delivery of Elisa's baby, a tiny girl named Louisa, was celebrated as a miracle of modern medicine. The official narrative was one of protocol and clinical excellence, and I did nothing to contradict it. But the story of my dedicated, round-the-clock care for the mother had circulated, reframed not as eccentricity, but as profound, humanistic compassion. The nurses who had once whispered now looked at me with a new, quiet respect. Dr. Costa, the no-nonsense attending, pulled me aside one day. "What you did for that family, Grace, it was more than nursing. It was ministry." He didn't mention protocols or efficiency. He saw the result, the human result, and it had touched him. I didn't try to explain the tear or the blood pressure spike. The evidence was in the outcome. A child was alive. A family had a future. My methods, once seen as a liability, were now being viewed in a different light. This small crack of acceptance gave me the courage to change my approach. I stopped trying to storm the fortress with grand confrontational arguments. Instead, I began to plant seeds. I started a silent patient initiative on my own ward, a simple, voluntary practice where nurses would spend just 60 seconds at the start of their shift speaking to their non-responsive patients, explaining who they were and what care they were about to receive. I presented it not as a challenge to neuroscience, but as a tool for nurse mindfulness and a practice of basic human dignity that could only have positive effects. To my astonishment, it caught on. Nurses, burdened by burnout and the dehumanizing grind of the ER, found a small moment of connection in that minute. They reported feeling more grounded, more connected to their purpose. It was a small thing, a tiny deviation, but it was a start. The resolution was not a dramatic overthrow of the system, but a slow, quiet integration of a new consciousness into its cracks and crevices. I had learned that you cannot change a protocol with a story, but you can change a heart. And changed hearts eventually rewrite the rules from the inside out. The path to the conclusion was not a straight line to vindication, but a winding road toward a quieter, more sustainable form of revolution, one compassionate moment at a time. So, how did a dying man's blink during CPR ultimately change a protocol forever? It wasn't through a dramatic top-down decrees from the hospital board. There was no official memo that landed on our desks announcing a revolutionary new standard of care. The change was far more organic, far more human, and in many ways far more permanent. It began with Louisa, Eliza's daughter, who thrived in the NICU, a living testament to the impossible intersection of death and life that I had witnessed. Her father, grateful beyond words, didn't just thank us for saving his daughter. He specifically thanked me for honoring his wife. He told the hospital administrators that my presence, my words to Eliza, had given him a sense of peace in an otherwise horrific nightmare, a feeling that his wife had been a participant in her daughter's salvation, not just a biological container. That kind of feedback from a grieving family carries a weight that clinical data often lacks. It plants a seed in the institutional conscience. Around the same time, the small, grassroots silent patient initiative I had started began to show unexpected benefits. Nurses who participated reported lower levels of emotional exhaustion on their burnout surveys. They felt more connected to their work, finding meaning in those quiet moments of spoken care that transcended the mechanical tasks. This data, though anecdotal, was compelling to unit managers struggling with nurse retention. A practice born from a spiritual belief in covert consciousness was now demonstrating tangible positive outcomes for staff well-being. Then, a few months later, a formal research study was published in a major medical journal. It was a multi-center trial investigating the incidence of covert consciousness in patients with traumatic brain injuries using advanced EEG monitoring that could detect brain activity invisible to the naked eye. The results were staggering. The study confirmed that a significant percentage of patients deemed vegetative or minimally conscious were, in fact, fully aware. Their brains responding to commands and stories in ways standard clinical exams could never perceive. When that study circulated through our hospital, the atmosphere shifted palpably. The anecdotes were no longer just anecdotes. They had the backing of hard, quantifiable science. Dr. Almeida called me into his office again. This time, the thick binder on his desk was the new study, not my old folder of notes. He didn't apologize, that wasn't his way, but he did something more meaningful. He acknowledged the convergence. It seems, he said, his tone thoughtful, that the map is finally beginning to catch up with the territory you've been describing, Grace. He tasked a committee, which included me, with drafting a new set of supplementary guidelines for the ICU and ER, a consciousness-presuming care protocol to run in parallel with our established life-saving measures. It included mandatory, documented verbal engagement with all non-responsive patients, family education about the possibility of covert awareness, and a lower threshold for neurology consults involving advanced monitoring. The fortress hadn't been demolished, but a new, more compassionate wing had been added onto it. The protocol, in its own slow, bureaucratic way, had indeed changed forever, not because it was forced to, but because the collective heart of the people upholding it had been softened and opened, one story, one tear, one baby's cry at a time. My journey, which began with the terrifying, intentional blink of a man I thought was dying in my hands, taught me a final, profound lesson about the nature of healing. I went into nursing believing that healing was a battle we fought against disease and death, armed with technology, drugs, and unyielding protocols. We were soldiers on the front lines, and our weapons were our knowledge and our efficiency. But I've come to understand that true healing is not a war. It is an act of sacred witnessing. It is the courage to stand at the precipice of the unknown, to look into the abyss of another's suffering, and to affirm, without a shadow of a doubt, I see you. You are not alone. The protocols are our tools, our necessary scaffolds, but they are not the soul of the work. The soul is in the space between the compressions, in the silence after the ventilator hisses, in the unbreakable thread of attention that connects one conscious being to another, even when one of them appears to be gone.
João, Samuel, Lucas e Elisa foram não anomalias ou médicas curiosidades. They were my teachers. They guided me from a world of black and white certainty into the vast, gray, and breathtakingly beautiful landscape of the human spirit. Realmo onde consciência é não simples on-off switch, mas deep, misterioso corrente que pode fluir beneath the stillest of surfaces. This is the moral I carry with me now into every shift. We must never let our maps of reality become more important than the territory itself. We must have the humility to admit that for all our science, we are still beginners in understanding the full spectrum of human existence, especially at its most fragile edges. The greatest protocol, the most important one we will ever write, is written not on paper, but on the human heart. It is a protocol of profound respect, of radical empathy, of the unwavering belief that every person, regardless of their outward appearance or clinical diagnosis, deserves to be spoken to, touched, and treated as if they are fully present, because we simply do not know the incredible, silent journeys they may be on. That dying man's blink was not an end. It was an invitation to look deeper, to listen more closely, and to remember that our role as healers is not just to save lives, but to honor them in all their mysterious, magnificent, and often hidden glory. And in doing so, we don't just change protocols, we change the very experience of what it means to suffer, to hope, and to be human in the face of the great, unknown transition we all must one day make.